All right, guys, so I know that we've talked about the dangers of falling into the symptom or the diagnosis-driven thought process and the symptom-driven thought process. And just saw a patient that I want to go over with you really quick to show you how fast the wheels can come off and how far wrong you can go if you are thinking about where the symptoms are, what the diagnosis is, if you let the patient think they know what the diagnosis is because that's what their physician told them and they're getting imaging and the imaging is going to tell them what the problem is. So watch how fast this goes sideways if you play the conventional medical game, okay? So patient that I've seen before has come in before for bilateral foot problems. So he's got pretty much feet that are fused, knee replacement with revision, actually he had a hemi years ago, then had a total years ago, then had a revision this past year, all on the left knee. So we know this is a problem. But he's coming in with sciatica. So his diagnosis from his primary physician is sciatica, and he wants to know what to do for sciatica. And he's got imaging scheduled because, of course, if you have sciatica, that means you have a herniated disc, and we need to figure out where that herniated disc is. So when I'm watching him walk, so we worked on this leg, he's still a little bit weak, still like when you watch him do a single leg squat, this side is weaker, more unstable, more painful than the other side. So that's still kind of a continuation of what we were working on a couple months ago after this last knee revision. But he wants to know all about sciatica. So I watch him move through the functional screen. I can see glaring issues. He's got low back pain here. He's got hip pain here. And so when I asked him, well, why do you think you have sciatica? He said, well, that's what the doctor said. Okay, but why do you think, like, what's the symptom that you think is sciatica, and what did you tell the doctor that made him think it's sciatica? He said, well, I have pain down my leg sometimes. I was like, okay, so show me where you have pain down your leg. He doesn't trace posterior thigh down to the lateral lower leg. He traces like lateral thigh, okay? So when I have him bend over and touch his toes, he can bend over and touch his toes, no problem. He can lean back, a little bit of a low back pain, no radicular symptoms. Squats, double leg squat, just fine. Single leg squat, obvious weakness and instability left versus right. So he's doing nothing that makes me think that he has sciatica. And I tell him, well, I kind of doubt that you have sciatica. He's like, well, what's going on? And I said, well, you need to remember, and what you need to remember is that patients have multifactorial things that are going on, okay? So just because every once in a while he has pain that's going down his leg, even though it's the lateral leg, even though he has that, doesn't mean that it's just sciatica, even if it was, which I don't think it is. He's also got a low back problem. He's also got hip problem. He's also got knee problem. And he's also got both feet that are terrible. Okay? So he's got multifactorial things going on. So what I told him is, that's fine that you're going to go get an MRI, but what I want you to do once you get those results and they tell you that you have herniated discs and they tell you that you have degenerative disc changes and your lumbar spine has bone spurs and this alignment's off and that alignment's off, is take all that information and forget it because it has absolutely nothing to do with what you have going on. And he said, well, how do you know that? And I said, well, because the picture that they're going to take of your back shows you the way your back has been for probably 5, 10, 15 years. That stuff didn't change 2 weeks ago when you started having leg pain. That stuff has been there for a long time. So that is not the problem. And if it is the problem, it's only a portion of the problem because we have all this other stuff going on that's feeding into this multifactorial symptom, not a diagnosis. So when he keeps saying, well, do I have sciatica? I said, well, you might have sciatica every once in a while. So remember, when you see your patients, you're seeing a snapshot. So his biggest complaint was 2 weeks ago, he flew out to Ohio to go to the Ohio State game, sat in the bleachers, flew on a plane, slept in a different bed. Would all of those things feed into what he's going on? And was that snapshot of 10 over 10 pain that he had sitting in the stands the same thing that he has now? Or was that a different scenario because of the factors that were feeding in to what was going on at that time? Flying in a plane, he's a big guy. Sitting in stands, not comfortable. Sleeping in a different bed, not comfortable. Okay, so don't jump on people that have some type of symptom that you think is a diagnosis when they've got multifactorial things and they're only reporting a snapshot of what's going on when they had symptoms. Because now when I see him, he doesn't have any of the symptoms that lit him up 2 weeks ago when he was at the football game. Does that mean that all that stuff is gone? No, that means he was in a totally different scenario, which gave him a different presentation, which gave him different symptoms, which means that problem then was due to what he was doing then. This problem now is due to what he has going on now. So if we fall into the, you have this diagnosis, I give you the 5 magic exercises and the 4 magic stretches on the handout that says this is what you do with sciatica, you will lose. Okay? And you'll let him continue to think that he has a problem that he doesn't have. So when he keeps on pushing me for what's the problem, I say, well, when I test you, you have some things that make me think you have a hip problem. So when I take him into 90-90 passive range of motion hip rotation, he complains of hip pain. When I test his rectus fem and his vastus intermedius, he complains of femur pain, which this femur pain could be the pain that he's talking about that's going down the outside of his leg. Then I also know that he's got foot problems and this knee is still unstable and weak from the litany of crap that he's had going on with that knee for years. Okay, so what I told him is, I bet you have degenerative changes in your back that have been there for a long time, that when coupled with this hip problem that I think you have, and coupled with the knee instability and lack of range of, or lack of strength here, and the lack of range of motion and stability in your feet, and possibly a femur problem, that's why you're having symptoms. Now, after I saw him last time, when I told him all this stuff, I gave him some really easy things to work on. And so when he came back today, I said, how are things going? He's like, well, I'm back to the gym. I'm not doing squats and I'm not doing leg press because I don't want to put load on my back. And I said, that's fine, do whatever, as long as you're doing the things that I gave you. And he said, yep, I'm doing those 3 times a day. And every time I do those, I feel better. Range of motion is better. I check my screen and everything feels better. So we know we're getting a hold on what's going on, and I'm not treating anything that would have to do with sciatica. So if we reverse, and I got the script from the doctor that says, patient has sciatica, imaging is ordered for lumbar spine. And I said, oh, well, you have sciatica because this piece of paper says that. Let's do nerve glides and let's do stretches and let's do mobility crap and don't go to the gym. He would have been worse on his second visit had I gone down the diagnosis-driven treatment program versus the patient presentation of multifactorial things going on at different times depending on what he is doing. Okay, so this is why you went to school. They should have taught you critical thinking in school so you can go through this process and figure out what you're treating. Because today when I saw him, I treated things that were different than what I treated the first time that I saw him. And next time when he comes back, I'm going to treat things that are different than what I treated today because he's progressing. So if you're falling into, well, we do these things because that's what the diagnosis is, that's probably what you're going to do on the second visit and probably what you're going to do on the third visit and probably what you're going to do on the fourth visit. And since it was the wrong thing on the first visit, it was the wrong thing on the second, third, and fourth visit too, which is why they don't get better, which is why people don't finish PT. All right. So post your questions below. Again, my bet is MRI is going to come back for HMP, DJD, spurs, whatever. They're not even going to look at his femur, which I wouldn't be surprised if he's got a femur fracture, stress fracture, something like that. Now, did I bring that up with him? No, because now he's going to go crazy on that. So he's getting his MRI on Friday. His symptoms are going down. His functional ability is going up. So I'm not going to throw more things into the mess to mentally screw him over. Okay, I'm going to let him continue to get better on a functional level because we're getting into physiology. So, and I already talked to him. You know, we did this knee a couple months ago. You felt fine. You didn't do PT for a couple months, and now things are coming back. I told you this is going to be a long-term thing where you should probably be coming in like once a month just to make sure that this is going well. Since he didn't come in for 3 months, went on a plane flight, sat in stands, slept in a different bed, things fall apart faster. So all we're going to do right now is get him back to where he was when I stopped seeing him 2 to 3 months ago. And my bet is this pain that's going down his leg is going to greatly decrease or disappear depending on if he's got something going on with his femur. And this low back pain and hip stuff is going to greatly disappear or greatly go down or disappear depending on how functional we can get him and how much he has to compensate for the structural limitations that we're always going to be dealing with. So hopefully that makes you think the next time you see a patient that comes in with a diagnosis or you have a multi-diagnosis person that you have to take all of this stuff into consideration. Okay, so if you know they have a history here and a history here and a history here, you can't just go here and say, well, that's the problem. You have to say, we have a multifactorial thing here. I have to use my critical thinking to get to all of these factors, address all of these factors on a physiological level, and then move forward. And when you have a systematic thought process and a screen, pre-screen and post-screen that gets you to that point and then helps you go right into exercise, this becomes a very easy patient that we're gonna get better in 2 to 3 visits and keep moving forward, rather than stick him with a diagnosis and follow that broken thought process and he gets worse and wouldn't be shocked if he ends up in surgery because he sees some back guy that's all he knows. Well, you have a herniated disc. You said you have some kind of leg pain, so that's obviously it. Let's go do surgery. Okay, so think about that. Post your questions and comments below.